Jen, do you mind repeating? Okay, I'll just repeat the question. So the question is around whether there has been any plan to link the LACs in with the settlement agencies. Is that? Yep.
I just had a question for you, Christine. I was just interested, you said if an application was rejected, to get that information as to why and then pursue it from there. I was just wondering how easy it is to get that information about why an application might have been rejected.
We haven't found it hard. They usually it's clear why they've rejected it, and it's usually one of those two reasons. This is actually a medical problem, or if someone's gone to the plan, when the assessment form comes back, they've usually said this is because it's a medical problem, or the person isn't really disabled. Classic examples where that occurs when it's around pain, or there are multiple medical conditions that are interacting, but they haven't picked up that, it hasn't been accepted that they actually result in a disability as well. And the psychiatric disability, the NDIS is not going to actually fund a psychiatric disability, but they will do it for a psychosocial disability. So we haven't articulated it that way. But usually it's those reasons. They're not disabled, or they're not actually. It's a health problem.
Okay. I think we've got another question here as well. But
I just wondered if you had seen it turned around.
Yes. No, it's well worth appealing. Yeah. Yes, especially for psychosocial disability. Yeah.
And all that information comes back to you in a written form that you can then address.
Just with those two statements, yeah.
Yeah, okay.
So I suppose you have to read between the lines and see what was, Yeah.
Yes, just a question for you as well, Christine. The difficulty of providing evidence of an intellectual disability in an adult across a language barrier, please. Have you got any pointers, any assessments that we can use?
Oh, that's really difficult. Yeah. I have tended, when the person has an intellectual disability, to focus on the other disability, psychosocial disability. It's actually very difficult to do a cognitive assessment cross-linguistically. So I don't have a solution to that, and none of the tools that they have actually will apply to those. So I've tended to go for another disability. If the person had solely an intellectual disability, then I think we would have to call the neuropsych people in, and that, I don't know about here, but in the ACT that's a long delay.
Yes. The other question is, do you see a value in having an occupational therapist do an assessment and provide a report?
That's very valuable, really valuable. They really love it. Wouldn't that be true, Jen? They love an occupational therapy assessment.
Yes. Yeah. So for the Refugee Health Network, do you have a list of OTs that are prepared to bulk bill and work across a language barrier?
Just in reply to the question about the list of OTs that are willing to bulk bill or use interpreters. So both Brisbane South PHN and Brisbane North PHN have an Interpreting for Allied Health Professionals program where we provide free access to TIS. And the South side do have on their website a list of providers who are happy to put their contact details on the website, and it does say whether they bulk bill or not. And then the Brisbane North are also working on a resource like that for their website, so keep an eye on their multicultural health page.
Sorry, again for you, Christine, I'm sorry, you're the person who has all the up-to-date experience. I know you mentioned a few times that'll be the LAC role in Queensland, but really I'd like to know who's funded in the ACT to provide all that pre-support in terms of access and pre-planning.
So we don't have an LAC, and we had this head start with this pilot project. So that was really good because it kind of superpowered some of the publicly funded, like the mental health service, for example, to actually get the capabilities and to be able to do it more efficiently. To start off with, it feels like a very inefficient process, but once you've got the hang of it, it doesn't feel like that. So what we have in the ACT is a companion house, which is our medical service, so for refugees, and they have 3 advocacy workers. We've increased our advocacy workers around this issue, but also around housing as well, and mental health services. And there's the equivalent of your service in the ACT, but also it's the disability advocacy service that does the planning. We don't have an LAC, and we just have the ACT, and some trained up services. I think you're trying to train up the LAC, so it'll be an interesting time.
Why I'm asking that is people like us, AMPARO, are not funded to do that. So until the LAC comes on, about 50% of the families that we've seen are not linked into any services. So they can't go to some of the services who are helping people with pre-planning and get support by them because they're not linked into any services. And of course, even when you do go to someone that you're linked in, then there's that question of choice and control in terms of if the current service provider is helping you do your pre-planning, then possibly they've got an interest in how they help you with that planning. So I'm just, curious about how does your medical service get funded to help with all of that at this stage?
Companion House is the equivalent of QPAS with a medical service in it. So it's got, there's a lot of resourcing around settlement, the early settlement period. So there always was a couple of advocacy workers who did housing. So their job, because there's public housing stock's shocking in the ACT. So those people just expand. There was government funding to expand their roles. There was government funding in the Indigenous sector to expand their roles. That was in the early days. I really recognise that that was a great advantage for us. Yeah.
Thank you.
Actually, just wondered that perhaps, on that note, Ruth or Peter might be able to add a little bit, to that question about who could provide that support.
Where do I start? Let's unpack the question. First of all, the notion of a plan or a planner. When the NDIS uses the term planner, it's not what we would understand the role of a planner to be. When I use the term planner, I understand the role of a planner as somebody who deeply engages with the individual to understand who they are, the context that they're in, and the style of support that they require in order to engage with community life and to be included and to participate. That's what a planner does. If I commence a plan with the individuals who I'm engaged in, 3 months minimum, to put that on the ground, to just articulate the plan. So when the NDIA uses the term planner, it refers to either the work done by an LAC or an NDIA planner. And essentially what they are doing over a couple of hours is collating information that will then be formulated into a plan that then is collated into the funding that an individual receives. So that's that part of the answer. The other one is that the notion of an LAC grew out of Western Australia, and it was a community development function. So what an LAC would do is work in a community with disabled people and their families in order to identify opportunities for them in that community and connect them up. That's what it was. And they had some resources available. That idea was taken up in the NDIS, in the NDIA, as like a community navigator. However, what occurred was that the planning functions were added into that. So our real experience is that while the role of LAC is really broad and developmental in its orientation, in fact, the role of the LACs is taken up doing planning. And given the delayed rollout of the LACs, I think that we can reasonably expect the same experience for LACs in the Brisbane jurisdiction as we experienced in Ipswich, Toowoomba and Townsville, that is the majority of time of LACs is taken up in the planning process. Now, that may change over time. My experience on the ground is that it's not that LACs are relatively invisible. That may change with the new pathway, but given the workloads, not likely to happen. So for my personal opinion is that the NDIA is rapidly approaching the time when they're seriously going to have to consider funding individual planning in that pre-stage, so that we are building the capacity of families and individuals, firstly to understand what it is that they want to achieve in life. Secondly, to understand the supports that they might require, both the formal and informal supports. And then thirdly, how they might articulate that within the NDIS context. I don't think that we can avoid having that serious and really basic conversation. Otherwise, what we end up with is inferior plans, as has already been articulated, firstly, and secondly, not leveraging the real capacity of the NDIS, which is choice and control to deliver on social and economic participation. And that's why over 500,000 people in Australia advocated for this fundamental social policy change. There you go. That's what I reckon.
Thanks, Peter.
Well, from our program, CARES Queensland, I guess, yeah, we're all looking for funding, yes, to have the capacity to have that conversations with the families, which is what is taking a long time in getting really familiar with needs, services, how to meet some requirements for that services. I think it's not only the diagnosis part, which is so important just to access the NDIS, but it's also to understanding how that supports are available in Australia and how they work, because you can get or access some support, let's say personal care, but many of the families just has been survived by themselves and they expect to have that support in that way that they do. And they have a big shock when they get someone, with all the regulations, health and safety issues, getting home and just doing what they don't really expect to do. So I'm thinking from our experience with a couple of families who are NDIS eligible in Brisbane, we have, taking the time to make that conversations with them and just try to get them familiar with services, needs, but also, within many of the families who have low literacy in their own language, but also in English, they don't have any picture about what is an inspiration or good life. I think families are so grateful in terms of having a safe place to live and have something to eat and have a good bed, let's say, to sleep. And that's important for them, but just thinking about other possibilities in terms of linking with the communities, do some sports, undertake some studies. It is a big conversation for them, and to realize how far the loved ones can, go is just taking a lot of time. So we have a lot of families who have been referred to other services who do readiness of the program, of NDIS, some workshops and things like that. Then still they are confused about, what is the conversation about? And I think it is when we need to get more support. CARES Queensland is, the multicultural program is giving that support to families. We are taking time to, again, let's discuss, what is the needs, what are aspirations, and just try to show examples for people to really get that picture of, someone in Australia, how far they can go. But it still is a lot to do with these families that, I think, I don't know who else is doing that, but we try to do our best as a call program, but we don't find many services doing the same, to be honest. When it's a workshop about talking about NDIS, it's just one workshop one day. Some service providers, even they can have a little bit of part on, what is going to happen with choosing as a service. They are doing a good job with some families, but others is, of course, is a little bit of business issue there.
Thank you, Ruth.
Donata, you had one last question, perhaps?
Firstly, thank you so much. It's been wonderful to hear from everyone's perspectives tonight. As you know, we've got a network, a Refugee Health Network Queensland, and my question is, we've got a policy which is focusing on health and well-being, and we've got an opportunity, I guess, to provide some leadership or provide some advice or bring people together. What do you think are the one or two key priorities, or a single issue that you think it'd be worthwhile for the Refugee Health Network to focus on, so that we could either reach out to primary care, tertiary services or communities through our e-newsletters or through our working groups, etc. Just one or two things that we could take away tonight and work on in the next 12 months.
Do you still have a microphone?
Thank you. I think engaging with the communities is the most important thing. That is mainly through education. As you know, speaking particularly about my community, but this is actually common with many communities. We are from a non-English speaking background, and we understand that most of the resources for awareness, for everything, most of them are produced in English. So some of the communities don't only speak English, but many of the people are also have no or less literacy capacity in their own languages. Like in my community, we have around 80% of people don't know how to write and read our own language, which means, educating them, we need a lot of efforts, because it's not only working on English, it's also working on their own language. Because like, if you can't get a material that you can't read, it's really hard. When you get it, you will not be able to read it. Our children, they know English, but they don't know our language. So we have less family help. We have less help within our families, because we cannot cooperate with our children to get help from them. They don't understand well our language. They are much more focused on English. So engaging our communities to make them understand everything that they need to understand, it should come through engaging the communities, including involving leaders and working with small groups, and trying to reach people one-on-one. So it's more using the community members a lot. Apart from the interpreters, interpreters play a big role, but we really need to also use more community members, to those who are capable in terms of English and in terms of our own language also. And also, like taking an example of my role as a community education worker with AMPARO, it has helped me very much to have an intensive training about this specific topic, which is disability. Because even myself, I know English and I know my language, but like if there wasn't enough time for me to get trained, to know the terminology, because I told you, we have a lot of disability types that we are not aware of in our country. So we need a lot of time to study about that, because before going to my community and deliver information about certain topic, I have to know it fully, because there's some mental disabilities that really do not exist in our country. They are, but we are not aware of that. So we need bicultural workers, and whoever is helping in the community needs to be trained enough. And then maybe getting a big number of trained people would be very helpful, because we are huge communities. Like my community, we are a lot of families. We have a lot of people. You know, we are encouraged to be big families. So, which means there's a lot to do. So, like getting a community, specifically like the Burundi community of Queensland, one person is not enough. I can't cover everywhere. I can't. So it's good to teach people to help their people, but it's good to equip them enough. Have I answered to the question? Thank you.
AMPARO is aware of the work that the Refugee Health Network has been doing around the cognitive working group. I think Queensland Health has to step up to the mark, and whether we need to have a stronger advocacy role to ensure that Queensland Health actually puts resources in so that there are actually trained people who can do cognitive assessments or neuropsych assessments, so that people can not wait for 10 months or 12 months or longer to get an appointment at the private or public health system, so that they can access the NDIS in a timely manner, because these assessments are quite costly if you're going privately, and even privately there's a long delay to have these assessments. So, you know, at the moment, diagnosis and assessments is the responsibility of health. So maybe it's influencing Queensland Health to actually put some real money into this so that people get access to the NDIS more quickly and access to assessment.
It's a very interesting question that you've asked. My background is occupational therapy, architecture and community development. So I'm really, in this space, I'm really intrigued about the question, what builds the capacity within communities to identify and attend to the circumstances that they find themselves in? So I think I'd be intrigued in exploring what would make it possible for the communities that you're connected with to work individually and collectively to identify the issues that are significant to them and barriers to them accessing the NDIS, and then what would it take to begin to fracture those barriers so that individually and collectively as communities they were able to take control of the agenda and turn it back to the NDIS and say, this is what we require, or this is what I require, as opposed to allowing it to be dictated the other way. That'd be intriguing stuff to play with, I reckon.
Yeah, well, there are so much to do, I think. But I'm thinking, you know, individual support to families is so important. So many of these families don't really want to link, or they are isolated, or don't really link with communities or, you know, other services. So we need services who are able to approach them in their own homes, you know, having that conversation, that is so important. So have numbers available about Care School and the multicultural program, AMPARO Advocacy, or, I don't know, community centers who still are able to have that conversation will be so important for them. But I'm thinking that the other thing, working with my families and try to help them to understand the scheme, and also even we do have families under Your Life, Your Choice, which is, it's a little bit of preparation what the NDIS is. And it has been so difficult to deal with budget, services, you know, possibilities. I'm thinking that showing like examples, you know, like AMPARO Advocacy have good videos where you can see some examples of successful stories and possibilities for families. But there are also organizations, different organizations who work in that opportunities, for example, Sport Willies. I think if you can see what they do, you know, with people to encourage people to get in a sport or be part of a club, you know, and, you know, be part of the community and feel happy and do something and develop some skills. So that is information that never came to that families at all. So it is why they try to just meet the very specific needs, but sometimes not really realize that there are other things where they can be involved with the right support. So we need to somehow encourage to share that experiences for people to get the most from the scheme, in my opinion.
Thank you, Ruth. Thank you, everyone. I think it might be time for everyone to wrap up.
No. All right, so thank you very much, everyone. I think if nothing else, we've seen that those of us in the audience and our presenters this evening were all very passionate people about offering the very basics of humanity to our clients and our patients, and I think we just need to carry that through as we see NDIS roll out inevitably in our area, and we hope that we will all obviously work together to make the very best for our patients and clients.